Yes.
Okay, great.
Hello, Olivier. I hope you can hear me well. Thank you very much for the kind introduction, and thank you, Pusen, for the invitation to have this talk. So, retrograde intravenous surgery and indications, the place of single-use flexible uteroscopy. This year's EAU guidelines for RIRS state that in experienced hands, stones up to 3 centimeters can be treated, and there is no size limit if percutaneous nephrolithotomy is no option and stage procedures are accepted. And as RIRS achieves higher stone-free rates than shockwave lithotripsy, it is an alternative, especially if unfavorable factors for SWL are present, such as a steep infundibulopelvic angle or very hard stones. Complex stones may be treated with an endoscopic combined intrarenal approach, allowing for visualization of the puncture site and branched calyces, otherwise necessitating multiple punctures. RIRS is also an option for the pre-transplant kidney, as retrograde access to transplant kidneys is difficult due to the anterior location of the urethral anastomosis and urethral tortuosity. And treatment of donor stones may be needed pre-transplant and increase the pool available for renal transplants. A systematic review evaluating the outcome of pre versus post-transplant ureteroscopy demonstrated a favorable 100% stone-free rate with an overall 7.5% complication rate compared to an overall complication rate of 13% for post-transplant ureteroscopy. In pediatric stones, recent studies reported stone-free rates of 75 to 100% with retreatment rates of 0 to 19%, and complication rates were rather low. So it is also an indication for pediatric stones increasingly with smaller instruments. In anticoagulated patients, RIRS is indicated as the only treatment option, as shockwave lithotripsy and percutaneous nephrolithotomy are contraindicated. The EU guidelines on upper urinary tract urethral carcinoma state that upper urinary tract carcinoma suggests nephron-sparing management as the primary treatment option, not only in patients with a low-risk tumors, but also in patients with kidney deficiency and severe comorbidities. In addition, for patients with multifocal up to 3 centimeter upper tract tumors with low-grade pathological findings, RIRS might become a more common treatment. In an in vitro performance study at the time with the first generation Pusen device, it was demonstrated that various single-use scopes can have comparable and even favorable characteristics in terms of weight, field view, resolution, and deflection compared to reused devices. The irrigation of flow of single flow use was even better than the flow of reusable scopes, or working channel being free or occupied with various instruments. So all in all, these data and also these papers provided here provide evidence that disposable and reusable ureteroscopes are comparable in terms of quality and efficacy. So in terms of quality and efficacy, the indications for single and reusable scopes are actually not different. But economic aspects, such as reduction of repair costs, potential risk of contamination and sterilization efforts, as well as additional waste and operator comfort, need to be taken into account. And this is especially true for complex procedures with large stones. Because with increasing stone volume, the number of fragments increases rapidly and necessitates multiple entry and exit maneuvers, increasing the risk for instrument failure, as do larger, harder stones in which OR time is longer compared, for example, to softer stones. Large tumors or large hard stones and a complex renal anatomy lead to longer lasering time, increased mechanical stress, and to more frequent instrument failure. The study from Ozimek et al., it's an image on the left side, Results here suggested that a steep infundibulopelvic angle, regardless of the complexity of the stone retrieval, influenced the durability of reusable devices. And the vast majority of flexible ureteroscopies defects occurred when the measured pelvic angle reached 60 degrees or less. And moreover, it was noticed that relatively many defects, more than 7%, occurred even in diagnostic procedures. So therefore, for example, the infundibulopelvic angle may play a potential role in device management, not only in typical cases with lower pole kidney stones. Regarding costs, we have another talk on that, but I just want to point out, this is a study from Marga et al., that depending on purchase prices, costs may exceed the lower limit of costs for reusable ureteroscopes. After a certain number of procedures, in this study, it was after 61 procedures, and in case of higher costs of purchase prices, the upper limit of costs for reusable ureteroscopes was reached after 118 procedures. So this prospective cohort study provided a realistic view on a program at a resident training University Stone Center performing flexible ureteroscopy. And depending on the amount of interventions and the case volume you have and the purchase price, it depends if this is a efficacy to use reusable or single-use scopes. Another issue is the carbon footprint, the waste. Flexible ureteroscopic raw materials comprise about 90% of plastic, 4% of steel, 4% of electronics, and 2% of rubber. The carbon footprint, which is a kilogram of carbon monoxide per case of reusable flexible ureteroscopes, was calculated using previously validated models for obtaining data on manufacturing, sterilization, repackaging, repair, and also solid waste disposal. Single-use scopes are by definition creating an increase of plastic and metal waste products. On the other hand, the lack of reprocessing could be more environmentally friendly due to the decrease in use of aggressive detergent, disinfecting products, a part of being carbon neutral. Of notice, none of the companies have an active program of collection and recycling of used disposable scopes with a consequent lack of preferred pathway for waste recycling. So this will probably change if consumption of single-use scopes increases as recycling will become more cost-effective. Bronchoscopes and gastrointestinal scopes most frequently reported as bearing pathogens regarding contaminations because of interventions. And if endoscopes do not attain a sufficiently high level of disinfection, they may cause outbreaks of healthcare-acquired infections. And there was a reported outbreak of an ertapenem-resistant Enterobacter cloacae urinary tract infection, and that was due to the disinfection failure of a contaminated ureteroscope, which had been colonized by the resistant clone. So if two consecutive or more patients develop infections after procedure, especially if the same clinically relevant microbial species are involved, the existence of an outbreak of infection should be highly suspected and a prompt investigation should be initiated. And this scenario might be avoided if you use a single-use scope, which can, by definition, not be infected prior to the procedure. So I come to my conclusions. And with today, single-use scopes, all retrograde intrarenal surgery interventions can be performed similar to reusable instruments. However, imaging features as narrowband imaging or PDD are currently not available in those devices. The indication for use of a single-use scope depends mainly on patient factors. And this is best for large multifocal ablative tumors or large hard stones harboring an increased risk of instrument failure. Second, Additionally, single-use instruments are indicated in complex anatomic situations, including difficult to access cartilages and in, for example, steep infundibulopelvic angles. Other indications depend on the surgical team and include, for example, complex procedures as endoscopic combined intrarenal surgery approaches usually, but also for teaching purposes, for example. For the nursing staff, it is convenient to open a single-use scope, dispose it, and directly after the procedure. For the surgeon, for example, the median thumb and wrist fatigue scores tend to be better in contrast to the standard reusable ureteroscope, especially in long-lasting procedures with low-weight scopes, as the Pusen has just 91 grams. And I think everybody who's doing long procedures appreciates lightweight ureteroscope. The hospital operator or the urology department may find single-use scopes more suitable for low-volume centers, since it may be a more expensive option at high-volume centers, but this is very independently, very individually to be seen, depending on many factors which need to be individualized for any institution: case volume, cost for repair, sterilization, staff, purchase prices. For scopes, they all need to be taken into consideration to define indications for single-use scopes. There is an interest to define indications for single-use scopes as they warrant the availability of intact instruments, avoiding time-consuming and costly rescheduling of patients, which is also very negative, and which will have a negative impact also on the institutional reputation. Then we have the environmental aspects, which also might influence decisions. However, at the moment, so far, there are no clear advantages for either device, at least looking at the carbon footprint, seeming to be comparable between both types. Regarding safety of contamination, so far only sporadic iatrogenic bacterial infections caused by insufficient sterilization have been reported. However, single-use scopes warrant additional safety as the potential catastrophic risk of infected spread by instrument contamination is eliminated. And although the clinical implications of contaminated scopes are currently unknown, the existence of pre-use contamination represents a good argument in favor of those single-use scopes. So finally, additionally to calculated costs, non-calculable benefits as improved ergonomics, environmental aspects, and rare but potentially cost-intensive safety issues all individually influence the decision for defining the place and the indication for the single-use scopes. So continued innovation and competition, I think at the moment in instrumentation development, will lead to further expanding indications being very likely more cost-effective. Thank you very much for your listening.
Thank you, Christian, for your excellent talk, and I would say excellent view regarding the place of single-use flexible ureteroscope. I really like a lot the view that you gave today. Christian, just few questions because we have few minutes. First, I'm still surprised to see that into the guidelines, we still keep these largest diameter to discuss indications between shockwave, flexi, and Pusen. When do you think that we will start to consider the total stone volume and, of course, the stone density according to the type of the stones?
No, I think you're absolutely right, and it is, I think, for everybody who's operating on stones, clear that all those factors you just mentioned very much influence the efficacy of any procedure. And the guidelines so far help themselves out, saying that in experienced hands, also the indications are wider. We can also treat larger stones. So this is a first step. But at the end, the guidelines reflect the studies, they exist. Yeah? It is something we have to look for the studies, for the evidence. And if it is reported, then the guidelines actually can react. And I think that, of course, the stone volume, the hardness of the stone, as you mentioned, and also patient factors play a crucial role And with additional evidence we have, and a lot of studies are out there at the moment, and there are a lot of publications, I think this will change accordingly within the next guideline publications.
Okay. And what do you think we are missing actually regarding single-use or even the regular flexible ureteral scalp, just to improve, to increase in terms of indications? What do we miss actually to do better or to go further in terms of stone treatment?
Yeah, I mean, regarding what can we do better, there are probably certain aspects. The first is, of course, efficacy of treatment in regarding stones. Another aspect is safety. And a third aspect is probably diagnostic accuracy, I would probably say. So these are the broad fields. And regarding diagnostics, I mentioned it briefly. So there are imaging modalities. They don't exist yet in the flexible single-use ureteroscopes regarding upper tract tumor identification, for example, that facilitates that. So I think that can be intensified, maybe the production in this regard. Other aspects, the optics, of course, the visibility improved, I think, a lot. And I think there's still more improvement possible that could help. Then we have certain issues with the diameter. We can use smaller urethral access sheets, especially now with the smallest 7.5 French flexible ureteroscope. So pre-stenting becomes probably less important. It will be more acceptable for patients if we can perform these operations possibly without stenting, with improved disintegration devices. They come also adjunct to the smaller flexibles. For example, the new lasers, we can have a more effective dusting, again, less residual fragments, again, less stenting. So these are all, I think, factors. We know about them, and partly they exist, but I think all of them can still be improved.
Okay, and my last question, Christian, is regarding, we have these two kind of instruments, actually. We have the single use, we have reusable. Of course, we know that single use is much better because it's a completely sterile instrument. And I must say that we are not completely honest with our patients when we are using the regular endoscope versus the single use. So do you think that we will be able to proceed for a long time, keeping both, actually, the reusable one and the single use one? Or do you think that we will very quickly move for exclusively single-use flexible?
I think I can talk for our institution. We actually completely changed to single-use scopes, and I think the tendency, the development goes into that direction. But there are factors, they influence that decision, of course, which I mentioned and which will come in the next talks here. But I think at the moment the development goes into that direction, yes.
Okay, excellent. Very interesting to know that. Thank you, Christian. It was a great talk again.